Welcome back to the equine anatomy lectures. We're going to continue the discussion on the equine forelimb. We talked about the importance of this topic. We mentioned a number of cases: navicular disease, laminitis, sole abscesses, etc. And then we talked about the 6 articulations of the forelimb, all the way from the shoulder to the elbow to the carpus to the fetlock, then the pastern, and then the coffin joint. After that, we talked about a number of muscles and a number of cases that are associated with these muscles, the supraspinatus and infraspinatus muscles, and the suprascapular nerve, which have the case Sweeney. After that, we talked about the long head of the triceps as one of the borders for the auscultation triangle for the heart and lung. After that, we talked about the tendon of the biceps and bicipital bursitis and olecranon bursitis, or capped elbow. We then did talk about a couple of muscles on the dorsal aspect of the radius, and those are the extensor carpi radialis and the common digital extensor. And we talked about a couple muscles on the ventral aspect of the radius, and those were the superficial and the deep digital flexor muscles and their tendons, of course. We mentioned the clinical relevances of both of them, and we also mentioned the passivity apparatus and the structures associated with it in the shoulder as well as in the elbow joints. Now we're going to continue the discussion. We're going to go to the carpus, and then we'll talk about everything that's related to carpus, from the passivity apparatus to the articulation to what forms it and things like that. This picture shows the carpal joints or the carpus. Well, the carpus consists of 3 distinct joints. And when I say distinct joints, I mean each joint has its own joint capsule. Now, they might communicate, but still they have distinct joint capsule. Each of the joints have a distinct joint capsule. And so the first of the 3 joints of the carpus is the radiocarpal joint. The radiocarpal joint, which is an articulation between the distal end of the radius and the first row of carpal bones. The second joint is the inner carpal joint. Inner carpal joint, intercarpal joint. It's an articulation between the first row of carpal bones and the second row of carpal bones. The third joint in the carpus is the carpo-metacarpal joint. The carpo-metacarpal joint, and that's an articulation between the second row of carpal bones and the proximal end of metacarpal bones 2, 3, and 4 respectively, medial to lateral respectively. This is a radiograph that shows these articulations: radiocarpal joint, inner carpal joint, and carpo-metacarpal joint. And so the first joint is the radiocarpal joint, distal end of radius, and carpal bones radial, intermediate, and ulnar. Again, this is medial, this is lateral. The inner carpal joint is an articulation between the first row of carpal bones, radial, intermediate, and ulnar, and second row of carpal bones, which is second, third, and fourth carpal bones, medial to lateral. This is a mislabeling. The lateral should be medial here, and the medial should be lateral here. So this is the medial aspect, this is the lateral aspect, and this is the radiocarpal joint, this is the intercarpal joint, this is the carpo-metacarpal joint, which is an articulation between the second, third, and fourth carpal bones, and second, third, and fourth metacarpal bones. And this is the joint here, which is in the radiograph is this joint right here. Now, the intercarpal and the carpo-metacarpal joints, meaning this joint here and this joint here, they communicate. So if you inject the intercarpal joint, the medication or the anesthesia will also go to this joint as well. The radiocarpal joint is a separate joint. It does not communicate with the other two. These are the two rows of carpal bones. The two rows of carpal bones. Radial, intermediate, ulnar, and accessory. Second, third, and fourth carpal bones. So radial, intermediate, ulnar, and then accessory, second, third, and fourth. The same thing here from the ventral. This is a dorsal view. This is a ventral view. You have the accessory. You have the ulnar. You have the intermediate and the radial. And you have second, third, and fourth. Now, what's the passive stay apparatus of the carpus or the carpal joints? The passive stay apparatus of the carpal joints consists of the flat dorsal parts of the mid-carpal joint. Mid-carpal joint. Radiocarpal joint. The carpal ligaments. And the pull of the extensor carpi radialis by the laceratus fibrosus tendon. These structures will prevent overextension of the carpus. See, the carpus is extended. You don't want to extend it more, so you don't want to bring it here to this level, here, into this direction. How do you do that? How do you prevent overextension? You prevent it by the flat surfaces or the flat parts of the radiocarpal and intercarpal joints, as well as the carpal ligaments, in addition to the pull on the extensor carpi radialis by the laceratus fibrosis. When you pull on this muscle, you keep this in the extension position and not in the overextension position. This is the stay apparatus of the carpus or the carpal joints. Again, the structures are the flat dorsal parts of the midcarpal and the radiocarpal joints, the carpal ligaments, and the pull of the extensor carpi radialis by the laceratus fibrosis tendon. The function of these structures prevent overextension of the carpus or the carpal joints, plural, joints, 3 joints. Now that we studied the basic anatomy of this carpus, what are the articulations, what are the bones that forms it, and how does the horse stand on it for a long period of time without stress on the muscles, tendons, or ligaments, because this is the definition of the passive stay apparatus. So it prevents it from overextension. Now we need to study some of the diseases on it. Karpitis is one of the common diseases that affects the carpus, and you can see the swelling of the carpus. Basically, sometimes it's just serum protein, so the exudate is a serum protein, and sometimes it's pus, depending on the type of lesion that we are talking about. Sometimes we have what we call a cyst, a bone cyst. We call it carpal cyst, and this needs to be explored arthroscopically and cleaned and see if it's not infected or anything. Another case is chip fractures. I showed you this in the very first lecture to show you how important studying the anatomy of the forelimb is. Chip fracture occur mostly in the third and sometimes the radial carpal bones, because these are the larger carpal bones, and they suffer more stress, especially in more stress compared to the other carpal bones, and especially in race horses because of the continuous friction between the surfaces here. So the third and the radial carpal bones usually are the most affected ones. This is the same lesion, but from a lateral standing position versus a flexed position. Now, when you have a problem with the carpal joint, we call that OCD, by the way, or osteochondrosis dissecans, or chip fractures. That's pretty common, and arthroscopic surgery is pretty common these days in equine to take out these lesions. Pretty frequent and pretty common as well. So if there's an infection, if there's a need to inject the carpal joints, if there's a need to do arthroscopy, we've talked about the landmarks by which we need to utilize to get into the 3 joints, the carpal joints: radiocarpal, intercarpal, and carpal metacarpal. The landmark is very simple, and that is medial to lateral to the tendon of the extensor carpi radialis. Pretty clear, and the joints are pretty spacious. You can just flex the leg, flex the carpus, and you will see the joints widely open, and you can put your needle again medial and lateral to the tendon of the extensor carpi radialis. Pretty common procedure, and Here's another view that shows this. You've seen this picture again. These are the two rows of carpal bones, medial to lateral, accessory, ulnar, intermediate, and radial, two, third, and fourth intercarpal bones. You have the tendon of the extensor carpi radialis and the common digital extensor. So your area is basically this here and this here, that you can medial and lateral, you can access you can access the carpal joint. Now this is the carpal joints, the three carpal joints. After that, we move to the metacarpal area. Metacarpal area. These are two pictures showing the metacarpus in the horse. And the metacarpus is or consists of the third metacarpal bone, or the cannon bone, we call that, and the two splint bones. The two splint bones, one on the medial side and one on the lateral side. The medial is the second metacarpal bone, and the one on the lateral side is the fourth metacarpal bone. Now, the third, which is the big one here, we call it the cannon bone. The cannon bone, right here. This area does not, or the metacarpal area, this area right here, does not contain any muscles. It's also here, this area right here. So it articulates with the distal row of carpal bones, second, third, and fourth, medial to lateral respectively, and then metatarsal bones 2, 3, and 4, medial to lateral respectively. So 2, 3, and 4 articulates with, or articulate with 2, 3, and 4. 2, 3, and 4 carpal articulate with 2, 3, and 4 metacarpal, medial to lateral respectively. Now, as I mentioned a little bit ago, the area, the metacarpal area, does not have any muscles, and instead it has tendons. It has tendons, and this area is pretty important, especially when you do ultrasound. So you have to know the structures, as we call them here, skin to skin, skin to skin. So this is the dorsal aspect of the metacarpus. This is the ventral aspect of the metacarpus. Dorsal, ventral. And we talked about these tendons. The only tendon, again, the only tendon that reaches P3 from the dorsal aspect of the forelimb is the common digital extensor tendon. The common digital extensor tendon. One tendon only on the dorsal aspect. On the ventral aspect, on the other hand, you have the superficial digital flexor. You have the deep digital flexor with its check ligament. Remember the check ligament, or the accessory check ligament. And you have the suspensory ligament running between the two splints bone on the ventral aspect of the third metacarpal bone. Only one of them, which is the deep digital flexor, reaches the coffin bone, or P3. Only one. So one from the ventral aspect, or the palmar aspect in this case, and then one from the dorsal aspect. The common digital extensor from the dorsal aspect, and it inserts on the extensor process of P3, where pyramid disease might happen, calcification might happen. We call that pyramid disease. And also we use it medial and lateral to that. We use it as landmarks to inject the coffin joint, or to get synovial fluid sample from there. Arthrocentesis, we call that arthrocentesis, or exploring the joint to get some synovial fluid. And on the palmar aspect, we have only one tendon, and that is the deep, the blue one here, the deep digital flexor tendon, which reaches P3. These are the structures that you will encounter in the metacarpus or in the metacarpal area. Again, these structures are the common digital extensor tendon, or the tendon of the common digital extensor, then the superficial digital flexor, the deep digital flexor, and its check ligament, and the suspensory ligament. Deep, superficial, deep, suspensory, superficial, deep, suspensory. On the dorsal aspect, only one, and that is the common digital extensor. The exposure of these tendons, because they're pretty superficial located, especially the superficial digital flexor, when it's inflamed, it gives you the shape of a bow, and that's why it's called a bow tendon. It's a tendonitis basic case. It's a tendonitis case, but because of the swelling, it becomes like a bow, and that is why it's called bowed tendon. Bowed tendon. That's very important. And as I mentioned, because these structures are very superficial, you can the best way to actually diagnose any of the diseases that affect them is through ultrasound. Look at this ultrasound image here. You can see this is the skin, of course, and this is the superficial digital flexor. This is the deep digital flexor. Of course, and ventral to that, you will, or dorsal to that, I should say, you will see the suspensory ligament. But here you can see this lesion right here in the superficial digital flexor. That's hypoechoic area. That's called a lesion in the superficial digital flexor tendon. Another 3D image of an ultrasound, so you can see the lesion in the superficial digital flexor. Now, in horses undergoing severe training or harsh training, what you have is sometimes, especially if horses are young, they'll have to encounter a couple of cases. One of them is periostitis. We call that buck chins. And the other one is osteomyelitis. The bone is basically is remodeled. So because of the training, the bones are basically regrowing again and again, and pretty fast. And that's a very important disease in horses. So especially in the metacarpal areas, again, because the bones are exposed. This is buck chins or periostitis of the third metacarpal bone. In the picture to the left-hand side here, this is from a study that showed that the thickness of the dorsal aspect of the trained horse, the dorsal aspect of the cannon bone, is thicker than in the untrained horse. This is pretty well documented. So the cortex basically is thicker in the trained one to basically carry more weight. Another case in the metacarpal area is splint fractures. Splint fractures. So the second and the fourth metacarpal bones usually are exposed to being fractures. They're thin bones, and sometimes if they get trauma or if they get any strain of some sort, they will rupture, or they will fracture, I should say. Now, the suspensory apparatus. The suspensory apparatus is basically the ligament that's running between the two splints bone 2 and 4 on the ventral aspect of the cannon bone, the third. What they do is they encounter insertion on the proximal sesamoid bones and they bifurcate, they divide and they continue on the dorsal aspect of the digits on P1 to basically unite with the one and only tendon that goes on the digit, and that is the common digital extensor tendon, as we mentioned, the one that inserts on the extensor process of P3, the pyramid disease place. So the two branches, if you will, of the suspensory unite with the tendon of the common digital extensor on P1, on the dorsal aspect of P1, as shown maybe in this one here a little better. This is the suspensory apparatus, and it's a very, very important because it forms also a passive stay apparatus for the fetlock. So we talked about the suspensory the passive stay apparatus of the carpus. Now we will go and talk about the passive stay apparatus of the fetlock joint. So the passive stay apparatus of the fetlock joint, this is the fetlock joint, which is an articulation between the distal end of the cannon bone of metacarpal bone number 3, the proximal sesamoid bones, and the proximal end of the long pastern bone, or P1. This is P1. So this is the articulation right here, and this is the joint. This is the fetlock joint. So what's the passive stay apparatus for this joint? The passive stay apparatus, or the structures that prevents overextension, I'm sorry, of the fetlock, because the fetlock is extended here, as you can see. The structures are the proximal sesamoid bones and ligaments, of course, and then the suspensory ligament. The structures that prevent overextension of the fetlock joint are the proximal sesamoid bones and ligaments, and the suspensory ligament. That's how you prevent overextension of the fetlock joint. Again, if you break this suspensory apparatus, then you are preventing overextension, meaning that you will have overextension of the fetlock, because the suspensory ligament will prevent overextension. If you break this suspensory ligament, overextension will happen, as seen in this case. Let's just summarize the passive stay apparatus of the forelimb. The shoulder is prevented from overflexion by the tendon of the biceps. So this is number 1. The elbow is prevented from overflexion by the collateral ligament of the elbow joint, as well as the fibrous components of the digit and carpus. The carpus and fetlock joints are prevented from overextension by, first, the carpus by the flat dorsal parts of the metacarpal and radiocarpal joints and their ligaments, as well as the pull of the external carpi radialis, extensor carpi radialis by the laceratus fibrosus muscle, and the fetlock is prevented from overextension by the proximal sesamoid bones and ligaments and the suspensory ligament. We just summarized what we've talked about earlier here. And this is basically the skeleton showing the forelimb. And this is the scapula, humerus, ulna and radius, carpus, metacarpus, fetlock, and digit. And this is the tendon of the biceps, which prevents over flexion of the shoulder joint, the tendon of the biceps. Here is the fibrous components of the joint capsule, and also the collateral ligaments of the carpus of the elbow prevents over flexion of the elbow. The carpus is prevented from over extension by the flat surface of the intercarpal and radiocarpal joints and ligaments, as well as the pull on the extensor carpi radialis by the laceratus fibrosus tendon, which is the internal tendon of the biceps, as I mentioned before. And the fetlock is prevented from overextension by the sesamoid bones, the proximal sesamoid bones and ligaments, and the suspensory ligament. Until this point, we have reached the last part of the forelimb, and that is the digit. We will start the digit in the next discussion. The digit consists of the fetlock joint, the pastern joint, and the coffin joint. We will talk about that in details next.